I like to say that I am a doctor of physical therapy. I'm an entrepreneur. I own my own business here in Atlanta now for a little over 6.5 years. I am close to publishing a children's book, which should debut here this summer in June. So we have a lot of great things to introduce to y'all, including a new business launch of mine, which will come this summer. Actually, not this summer. It will come much sooner than this summer. It will come within the next couple of weeks, as a matter of fact. My coaching business, as well as my online training to help entrepreneurs who are struggling to get their business structured properly, or those who have an aspiration to start their business. I am going to be that person to help you get it kicked off. With 6.5 years of success, I'm scaling my own business now with the help of my biz coach, Dr. Iyabo. I've actually hired a couple additional staff members recently. So I have occupational therapists. We did training today. I have 2 speech therapy candidates that I'm planning to interview next week. So we'll have a full team to be able to offer you not only physical therapy, occupational therapy, as well as speech therapy for all age groups. I am so excited. So let's get it going. Since I've said a little bit about you guys, I'll talk just briefly about my guest, who I think has already sent me an invitation. She is my buddy. She's my pal of over 20 years. We got some great stories to tell. Can't tell all of our secrets, but we have some good ones to share with you. We'll actually spill a little tea, but not too much. So her name is RHODES. She is a nurse here in the Atlanta area, and I'm going to let her give you more of her background because it's quite extensive, so I don't want to mess it up. So here we go. Hello. Rhonda, I'm coming on, okay? All right, Rhonda, I have arrived you. It says it's waiting, and now you're connected. Hey, girl!
Hey, how are you?
I am wonderful. How are you?
I am good. Thanks for having me.
You look beautiful.
Thank you. So do you, as always.
Look, what's that shirt? Let me see. What you got going? What's going on in that shirt?
Hold on. Let me make sure y'all can see this, because this is where it's at.
What I say? FAMU. Ooh. All right. Yes. That's the way we do it. We hail from the highest of 7 hills in Tallahassee, Florida, from Florida A&M University. Yes.
Where it went down.
Yes. Can you all hear us okay? Can I get a thumbs up for my volume if we're okay for sound? Thumbs up for volume, or thumbs down if there's a sound or a video quality issue. All right, we got thumbs up.
You got thumbs up?
We got thumbs up. All right,
okay.
So we are here today to have some very interesting dialogue about a topic that plagues our communities, especially communities of people of color. Heart disease is something that probably most of you know something about. Someone in your family who's had high blood pressure, who has had the males who've fallen dead at the age of 50, who have had some complications related to some of the side effects associated with heart disease. So we wanted to have a topic. I thought it would be a great conversation piece, especially since my friend Rhonda, who has worked in critical care nursing and cath labs, who's worked alongside cardiologists for a number of years. She is an expert in the area, and I thought she would be a great person to start that dialogue. But first, I want to make sure I give her the opportunity to give us a very well introduction of her and her professional background, her personal, anything she wants to share about her and her family. I'll give you the floor now.
Oh, wow. Thank you for that. Well, as Teresa said, I'm a registered nurse. I've been a registered nurse for 20 years now. I graduated from the best nursing school in the world, Florida A&M University. Been a nurse 20 years. I actually, when I graduated from nursing school, my goal was to do pediatric nursing. However, God had a different route for me. I hated cardiac when I was in nursing school, hated it. My teacher was so strict and wanted us to learn the heart backwards and forward, sideways. And I was like, oh my gosh, I can't wait to get out of this course. But what would happen is I ended up, my first job was in a step down unit. I did the step down unit for a year. And at that time, in order to go to a cardiovascular ICU, you had to practice for a year in a step down area. So then I applied and was accepted into a residency in cardiovascular ICU and have lived in the cardiac world for 20 years now. So I love it. I thank God for giving me healing hands. So it's a passion of mine.
Wow. So with that said, that is pretty impressive, by the way. I didn't realize you had did a residency in cardiac, the area of cardiac nursing. So that is pretty remarkable. Very hard to do, very challenging, but it definitely makes you more specialized in the actual area of your interest, and makes you stand out and allows you to have obviously more opportunities as it relates to your career and alongside your passion as well as your gifts and your expertise. We're so grateful to have had you on our team.
Thank you.
So with that being said, why don't you go a little bit into the some of the warning signs that we as people in general, but some things that may be a little bit more specific to women. Can you talk a little bit about some of the warning signs that people may overlook, they may have, but not necessarily pay attention to, that may be related to or to heart disease?
Yeah, so what I like to focus on is like women, because normally the symptoms that women have aren't the normal classic signs and symptoms of a heart attack or cardiac disease. So oftentimes we miss it because it's so subtle. And just working in this field and this career path has given me the opportunity to see and treat women who walk in the door and saying, wow, I have to have a quadruple bypass, and I didn't even know I was having chest pain, right? So like we have subtle jaw pain sometimes, and we chalk it up to, oh, it may be a toothache or something. Sometimes nausea, vomiting are signs and symptoms that we as women may have, opposed to the pressure, like the sitting on, I feel like an elephant is sitting on my chest. Not all women have that, and the scary part is 1 out of 3 women die each day from cardiac disease. Wow. So that's like every 3 minutes a woman is dying from it, Yeah. However, but if we could do preventative measures, or we knew those signs and symptoms like 2 years ago or 3 years ago, we could have treated that or prevented that.
Okay, so beyond just what we feel, there are other things that are happening oftentimes in our bodies that may already be happening before we even feel those symptoms, like the chest pain and the jaw pain, things like high blood pressure. Can you talk a little bit about some of the other things that may come before we get to that major event?
Well, we have risk factors, being African American women, our risk factors, our genetics, our heredity just puts us there. Unfortunately, the way our diet is, we have to learn how to have a healthy diet. If our cholesterol is high, and most of us don't know the difference between our high cholesterol and the low cholesterol, what's bad and what's good. So just being educated about that. Exercise, I know for me, being a busy mom of 3, although 2 are off in college now, even with the 1, I'm still busy with work, right? Work, virtual school, why? And then just my own personal, my own self-care. it's hard to just squeeze some exercise in. So we have to start, you know, for us, sometimes we don't prioritize and make exercise important, that priority for us, or taking care of ourselves. So those are risk factors that we can control. Smoking, if you smoke, those things lead up to cardiac disease. Diabetes plays a major role because it really narrows and constricts the vessels of the heart that supplies your body with oxygen and blood. So those are some risk factors that really plague our community.
So we have those, you talked about risk factors, and that's that there are like two sets. We have the modifiable risk factors, and that's basically our diet, our habits in terms of exercise, whether we're sediment or we're active. And then we have those things that are modifiable, like our genetics, you know, what families we were born into. And you know, even sometimes like
one modifiable factor that we can control also as women is stress. Our stress level can also cause us to have cardiac disease and or heart attacks. So managing our stress levels on a day-to-day also could alleviate any issues.
Can help reduce the potential for that being a major factor as it leads to heart disease. What I've seen too a lot of times is like with the high blood pressure, control of it seems to be a lot harder in our communities. And that's the people of color more so than others. And I think that is a genetic factor, but also I think there also may be some variables that we can control with the way we eat. And there was this guy, there's a pharmacist, Bobby Price. He went to school like you and I thought, you know, we were on the right track in terms of choices of fields, and he started doing the traditional stuff in the pharmacist, you know, prescribing medication, talking to people about how to administer, how to take it. And he was just noticing the trends that Black people came back oftentimes. You know, the blood pressure medicine was not treating the problem, it was just managing it. So what ends up happening is they end up having to take more medicine with higher doses or different combinations of medicine. So he was just like, this is not working. Right. And himself, he came from a family and he was very lean, he was very active, he was a very fit guy. If you saw him, you would never even guess, but he had high blood pressure and he had high cholesterol issues. And so he started thinking more about himself and literally how he could make a change. So he started with himself and on a journey of discovery, and he ended up exercising. He cut out a lot of like processed foods. He stopped eating meats. He went to pretty much a vegan diet where he was only eating plant-based foods. And he later went on and traveled to other countries because he saw it worked. His blood pressure went down. He didn't have to take any cholesterol medicine. He started educating even his patients about, look, okay, so they told me this was genetics as well. Right. Because my family had it, I thought I was supposed to have it too. Right. And he kind of bought that myth for a while until he started the self-discovery and completely modified his lifestyle. So he chose foods in particular, grains, nuts, specific to whatever issue he was trying to address. Right. And he used that as a medication through his foods. The book is called Vegucation Over Medication by Bobby Price. It's a very interesting book. I've read it. It's a pharmacist book, right? So the first couple chapters you can get through, but after that, it's a lot of like all these big words and you know, names of things that lay people would have a hard time reading. But even for like issues like fibroids, and the book is amazing. You guys, if you haven't gotten that book. And so he left traditional pharmacy. He does detox. He educates people. He travels the world. He went to Japan and Africa, and he studied. Japan has one of the largest number of people who live over 100 years old, centennials. And so he went there to study their lifestyle, to see what is it that they're doing that makes it so much better and so much easier for them, not only to live over 100, but to have good cognition, to be still riding bicycles, good balance, good control of their life and everything and their function. Right. And so he studied, and just to summarize it, he found that they had they ate very little meat. If they did, it was just like little pieces maybe mixed into something else with a lot of vegetable and grain products. Right. And it was very rare, maybe once a week. So there was no processed foods. They grew their own fruits and vegetables, and they rode bicycles. They walked everywhere. They didn't use cars like we do to get around. So there are things that we can do that can modify.
Absolutely.
And alter this. We may not be able to eradicate blood pressure and cholesterol issues on our own in terms without taking medicine. But I do think that if we start to educate ourselves more and get connected with people who understand us, he's a Black pharmacist, right, who understands us, our cultures, who studied more about how our bodies work, that maybe we could figure out a way to be healthier along the way. Yeah.
Right. Yeah. Well, I mean, I truly understand that, because I have my own story as it relates to that. You know, I've never had any hypertension issues, although my parents both have hypertension. I was like, I'm not going to have hypertension. I work out. You know, I try to eat healthy for the most part. However, with my third pregnancy, I got pregnancy-induced hypertension, which I was like shocked, like, oh my God, how did I get hypertension, you know? But even after delivering and even after losing 80 pounds, working out, I still continued to have hypertension. And it was devastating to me. Like, how is it that I have hypertension? I'm a healthy person. I've lost the weight. And my cardiologist really had to sit down with me and say, listen, it's genetics, Rhonda. Genetics. And unfortunately, you can't fight genetics, right? But I can control as much as I can of it. So for me, like, I don't eat a lot of beef or pork, mostly chicken and fish and vegetables. My biggest issue is carbs, right? So if I could modify that, maybe that'll help a little bit more. But it plagues us tremendously in our community and among, you know, African American women, unfortunately. And I wish there was a way that we could eradicate hypertension, because hypertension is a leading cause of heart attack.
Heart disease. Yes. So you said something interesting that made me think back. So when we were in school, we had to dissect cadavers, right? And we literally saw how different bodies structurally were different. Right. So like some veins, some arteries, some nerves in particular were not present, or some tendon that was present in some person's body may not be, or it may be somewhere slightly different, or maybe bigger or smaller. Or so in terms of genetics, like, because you've seen the inside of hearts, right? And so, like, have you seen, like, structurally speaking, and can you speak to that, like, literally from, like, how different it may look for families who have history of heart disease, different races? Is if that's a fair question?
Well, when it comes to the arteries and of the heart, so you have atherosclerosis, right? So that's the stiffening or stiffness of the heart, of the arteries. So African Americans, so I worked in a cath lab for years, and the good thing about it, just going through my career, working in a cardiovascular ICU, where I've managed patients who've had heart transplants, lung transplants, and bypass, and then being able to go to the cath lab allowed me to see it full circle, what's really happening with these patients, right? Our us as a people. So because of our high intake of fatty foods and cholesterol and saturated fats, our vessels tend to be stiffer or have the atherosclerotic look, right? So that kind of plagues us. And then of course it narrows. The more atherosclerosis that you build up, then the more narrow your arteries get, which ultimately prevents blood from getting through, which is what causes the chest pain, because there's no blood able to flow through the arteries, right?
Right.
So unfortunately, because our diets and culturally we wasn't raised to have a healthy diet, right? I know when my mom didn't raise me eating vegetables or a vegan diet. It is what's led, you know, the atherosclerosis, the high cholesterol, the diabetes, you know.
It's long-term stuff. It's not just what happened today. It's
right.
from accumulation over time, from our childhood all the way up.
Right. So, I mean, but I think like you having these type forums and the pharmacists who went and studied other cultures and the way where we are right now today, where we're able to promote a vegan lifestyle, and there's more opportunity or more choices for us to have plant-based foods, you know, even though it's more, it is a little bit more expensive, but that is at least an option.
It's an option.
Yeah. And you're able to get it quite frequently.
Yeah, and there are options like, okay, so even if you don't go organic, right? Which I know that's the healthiest way, at least that's what they lead us to believe today, is to choose organic foods. So even if you can't like afford to go organic, if you even just went to be more on the lines of your 4 to 6 servings of fruits and vegetables a day, cut out the red meats, cut out the porks, limit the protein, and you know, you can eat some protein here or there, but not, you know, try to limit it or balance the form that comes in a meat. So I actually do this periodically. I'll go vegan where I just take a few weeks. I green juice. I make juices out of potatoes, sweet potatoes, and other pineapples. So I mix things together and I make my own juices. And I'll just eat fruits and vegetables for a couple of weeks. And you know what? To tell you, to be quite frank, even my poop smelled better, y'all. I was like, well, it smelled just like my fruits and vegetables.
Right.
And literally, when they say you are what you eat, that was like a testament to me. I said, well, I could see. I darn sure can smell the difference. That's for sure.
And you feel different too. You feel better. You feel
lighter.
I mean, yeah. So I haven't this week and last week I haven't eaten any meat. So I've just been doing vegetables and I can tell a difference. Do I miss meat? Of course. But I mostly, like I said, I don't do a whole lot of pork and beef anyway. So, and chicken sometimes. So it's mostly my fish that I miss, salmon or seafood, shrimp or what have you. However, that's high as well. So, except for the salmon, you know, I could go eat that all day. However, I just wanted to see what my body would feel like and how I would feel with just being plant-based, veggies, fruits, your grains, your legumes, you know, and see how I would feel. And personally, I felt very good. Will I be able to keep it up? That's my goal, but it's a goal that you have to work at every day.
Yeah, because
it's a lifestyle change.
It is a lifestyle change. And once you learn a behavior, we've had these behaviors for 40-something years.
Right.
Some people may have had them even longer.
I had mine for 25 years.
I'm on mine, boo. I'm 48. I'm on mine. So I've had mine for 48 years. I speak for myself. But it's hard. So to create a new habit, I think it's like if you see this differently, some say 30, some say about 45 days. It's a range. So it takes a while for you to consistently do the same thing over and over and over again before you have a new behavior. And even then, sometimes we may fall off the wagon and not be able to keep up with it. But it's still, we always work in progress. And if you have a goal and something to shoot towards, as long as you're moving towards it and trying to change those habits, I think it's still, we could benefit from it. We could slow down our risk of having heart disease. So my mom was a smoker. She smoked from since I was a kid up until my niece was about 5 or 6 years, maybe 4 or 5 years old. And so what we know about smokers, obviously, it causes, deterioration, narrowing of the heart, all that stuff causes, changes in the oxygen supply to all the tissues. We saw cadavers of smokers in PT school, and the inside, they talk about that black lung thing. That is real. Not just their lungs, but the whole inside of their body look like, my shoe. If I could show you my shoe, I would. It's black. So, but what they do say, even if you stop smoking, that you can still, there's a chance that you can extend your life by stopping a habit that's bad, as long as it hasn't gotten too far gone. And so my niece is now 19 years old, and so she has, her quality of life is so much better. She used to cough a lot. She used to keep respiratory problems all the time. And she now realized how much better her life is, her air quality is, now that she has stopped smoking. And for me, cholesterol, let's go there. So that's another factor, right? And that can it's contributed to heart disease and strokes alike. And so for me, since I was in my 30s, I started, every year I would go for my annual physical. The doctor was, of course, checking my triglycerides, which I know what they are, my good and my bad cholesterols. And like each year, it was like, okay, 5 points a little higher. I'm literally running. I ran 3 to 5 days a week. I was kickboxing, and you see how lean I am. I'm barely 100 and, that many pounds. And
105. You remember when we was at FAM, we used to run Tennessee Street, and you would always be ahead of me. I was like, girl, go ahead and run. I'll catch up with you later.
And that's always been me. Each phase of life, I'm less active now than I ever have been, but even during that time, I was super active and following the recommendations for, daily exercise with 20 to 30 minutes of cardiovascular exercise. Right. I still was battling this progressively increase or elevation of my bad cholesterol. My good cholesterol happened to stay good, in a good place, but my bad cholesterol kept rising. So like a few months ago, my doctor was like, well, we looked at food. We've considered your activity levels and everything else, but at this point, I'm a little bit over. My total is like 220 something. It's like in that moderate range where it's at risk. Something could happen. Right. So finally, I was like, we tried natural stuff. I tried the red yeast rice, which is a Chinese medicine that supposedly works really good in other cultures. Right. Because I've had people who had it. They take it in 30 days. There are long-term research studies out there that say that 30 days of only taking this with no other modifications in food or exercise, people have had a drastic reduction in their cholesterol. Didn't work. Right. I took it faithfully. I had it rechecked. It didn't work. So I ended up having to go to prescription statins because I want to make sure I stay sexy for another 100 more years. So, right. and able to live. But that's the thing that I think I wasn't really ready to accept the fact that it was a genetic link. My mom has high cholesterol. She's thin too. you know, even though like we did not have the healthiest eating habits growing up, we ate fried food. We did have vegetables, but we did have fried foods
Right.
quite often. And we ate a lot of pork, and we had oils that were saturated oils,
Yeah.
not like olive oils, which are better oils because they break down in our system. They don't congeal on our arteries, like the Crisco oils and stuff that we grew
That
up
we
with.
used to cook in.
Right.
Yeah.
And I've been using all that stuff since I've known better. But it just didn't work. So I still say to everybody, we should try our best to get daily exercise, 20 to 30 minutes of cardiovascular exercise, and 3 days a week of strength training to try to do our part in the exercise department. And then trying our best to modify what we eat and how we cook in our meals.
Right.
I asked for a dietitian though, because I'm still feeling like, okay, I need some help. I need somebody to coach me a little bit further because yeah, I mean,
Well,
I
I
know
mean,
what I know.
you're kind of like me. Like, I just didn't want to accept the fact that I had hypertension. Like, I shouldn't have hypertension, right? You know, like that. It was very hard for me to accept it so much that I went to have echo after echo after echo. So they was like, Rhonda, we're not doing another echo on you. I was
It just is what it is.
I was
Yeah.
like, check my jugular veins, check everything. It was like,
Yeah.
no. So, I mean, unfortunately, I mean, like, I'm glad that you are aware and that you are making the modifications and you keep making them, you know, so that, and then see like 6 months, if you started, when did you start? What, October, November?
Yeah, I had blood work done about 2 weeks ago. So I'm just waiting to hear back on my blood work. So somebody has an interesting question. So I don't know. I have no idea. Rhonda may be able to answer this. What about blood types? Does that have
anything to do with it? So, hey, Sharita, thank you for that question. So, I haven't studied blood types that much. You know, when I hear people talk about eat to your blood type or eat for your blood type, I haven't placed a lot of research on that, so I can't answer. It wouldn't be fair for me to answer as it relates to blood type because I haven't researched that enough to see if what effect that has on cardiac disease and or any other non-modifiable risk that we have.
Gotcha.
But I think it's people who do study how your blood type affects you. They have a lot of information on you know what you should eat, how you should eat, when you should eat. You know, but I just haven't researched that enough to speak on it.
Gotcha.
Yeah, but I mean, I think for like I would be I would like to see what your cholesterol levels look like after you've made these modifications for like 6 months. Like but you're taking the statins now, so prayerfully they'll go down. But I would have liked to see if you did this for an extensive time, what it would have looked like with those modifications in your diet. You know, unfortunately though, we as African Americans are, you know, like I said, we're plagued with it, and our minorities too. You know, Latinos as well. So
yeah, I tried the diet modifications for years, and nothing was enough. So that's why I finally said, well, let's try this. And then I think once I get to the dietitian, we get my numbers regulated, and then I want to try to come off of the statins and then just use exercise, diet modification, and see if that will keep it at bay. And then so I'm going to give both a chance. My goal is to not have to rely on the statins long term.
Right.
But if that's the only method, then I'm going to have to do what I have to do. But I do want to try to find some more natural elements, especially in terms of food that can target my issue directly. And I think that's a good thing. We eat for comfort and not necessarily for healing, because
Right.
there are a lot of antioxidants in foods. There are anti-inflammatories in foods. Foods have a lot of, and there are also things that cause the opposite of that to happen. Cause us to have more bloating, cause us to have more swelling, cause us to have, more toxins to build up. So I think once we understand more about food, really, and what food we can eat that is designed specifically to target each individual problem, then education is such a big part. Once you know better, it's easier to do better. But if you don't know any better, it's really hard to change.
Right.
Yeah.
And even sometimes when you know better, it's hard to change it if you've done this, like you said, for 40 years, right? It's hard to make those modifications because we do what's easy for us. We do what's habit. But I do think education is very important as it relates to our modifiable risk factors, right? And just learning how to manage our stress levels and those things. Because for me, like I said, with hypertension, I started off on one type of one blood pressure pill, and now I'm a combo, even after losing weight and even after changing my diet. And so I'm like, I got to take a combination pill, So it's tough, but I would rather take that pill and have an opportunity to live a long lasting life as opposed to not, right? But I'm still going to do what I'm supposed to do as it relates to my diet, and as it relates to exercise. One thing I didn't do well is manage stress. And that affected my hypertension. I don't have cardiac disease, thank God. And my ejection fraction and everything is normal. However, my stress levels played a part in my hypertension. And unfortunately, so there's two types of hypertension you can have, and one is pulmonary hypertension. And mine, so your blood pressure consists of a top number and a bottom number, right? So that's systolic and your diastolic number. And that diastolic number, that number on the bottom, is the amount of pressure that your heart has to pump against, right? To push blood out into your body. So my diastolic was like 110.
Wow.
And so that means my heart was working hard trying to pump blood out to my body, right? So I was like, because I've worked in this so long.
Dangerous.
Like, oh my God.
Yeah.
Oh my God.
Very dangerous.
Oh my God, right?
Yeah.
So I really had to get myself together and under control, because you see the good, the bad, and the ugly, right?
Oh yeah. Oh yeah. You're on the other side of it. We know.
Right. And so when you see the good, bad, and ugly, as a healthcare profession, you automatically go to the ugly, right? You're like, oh my gosh, the worst is gonna happen. But fortunately, my diastolic now is 80, but the reason why I kept asking for echo after echo, because that looks at my ejection fraction to see how my heart pumps, to make sure that the pressure before, when my diastolic number was 100 or greater, didn't cause damage where my heart would not pump.
Recover from it.
Right. So it's like, I wish I had a rubber band to show what it looked like when your heart isn't able to pump. It's like having a balloon that you put water in, right? And it stretches so much, and then it doesn't go back to a regular size.
After a certain point in time.
After a certain point, right.
Gotcha.
So that's what that high diastolic number will do.
Gotcha. So it makes your vessels become incompetent basically over time, or the valve. Is it the valves in it that's incompetent, or is it the walls, or
no, the ventricle? So your
ventricles. Okay, gotcha.
Ventricle becomes sluggish, unable to pump.
Right. It's not efficient.
Right. So.
So you said something that was key. I want to stop for a second. You mentioned requesting having your ejection fraction. That thing, yeah. you requested to have it tested. So if you don't go in and say, Doc, look, now my blood pressure is down, would a patient routinely get this checked by their cardiologist? Is this a routine thing, or would they have to ask for it? Would they know? Like,
no, most cardiologists will check your ejection fraction.
okay, so that's pretty
right. It's pretty standard. If you are having hypertension and you're having any type of chest pain, or you're having any type of, if you have that risk, they're going to check you just because they want to have a base, right? A diagnostic piece to compare as you matriculate through life, right? So most of them will at least do one. Now they're not going to do 2, 3 like I was asking for, unfortunately, but you know, but they will do one, and you can get an echo at least once a year.
Once a year, but you have to request it probably after that first one.
Well, most of them will. Most cardiologists I work with are very diligent, and they will do what they feel is medically necessary. And getting that initial echo is definitely something they will do. Now, if they feel that you're getting worse or you're not managing well with your medications, they will do another one. You know, they will do more, but it's not something you're going to get all the time. No.
Gotcha.
But you know, there are several ways to diagnose whether hypertension or diabetes or anything is are those factors are causing cardiac disease. Like you can have a stress test. Most of the time they're going to do things that are non-invasive, so like a stress test or echo. When you get into invasive procedures like having a heart cath or a stress test that requires medication to alter the way your heart functions, then that's a little bit more in depth, which they may think that this is causing some narrowing of your heart, or they may think that it's affecting your ventricle.
Okay, gotcha. So we have seen a lot in history, like especially seem like in the last few years, of young males, athletes, just got to college, high school, just out of nowhere dropping dead on the either the football field or the basketball court. Most I hear football. Like I saw, even back when we were in college, I think there were some at Florida State. There were some incidents either right after and I recall hearing about. Would you like to talk a little bit about your thoughts in terms of sudden cardiac arrest in athletes?
It's very prevalent. So, as you know, I have 3 sons. 2 are athletes, and I've had opportunity to travel around the world with them. And when I hear athlete died because of sudden cardiac arrest, it really saddens me, because one, in our communities, depending on where we are, we don't have access to like AEDs, right? And if we had it and access to an AED, that's possible that we could save a life, right? So because it's becoming so prevalent amongst the athletes, I think it's something that we should start to talk about more. I have been thinking very hard. Up north in North Atlanta, there's an organization called Sudden Cardiac Arrest organization. But down south in South Atlanta, there's no organization. And what that organization does is it go out and teach athletes, teach or schools or colleges, and or like Boys and Girls Club, how to do CPR correctly. They give grant money, or they provide AEDs to every gym or rec center in those communities. Unfortunately, that organization doesn't exist in South Atlanta or McDonough or College Park. So it would be nice if we could have those same that same equipment, right? To save help save our kids or save our children. Unfortunately, because we don't hear about sudden cardiac arrest a whole lot, we kind of chalk it up to, oh, they fell out, or they just died, or passed out in court and died. But it's a reason, right? And also just doing a preliminary EKG and echo on athletes yearly to see how their heart is functioning, because I can remember when Malachi was playing ninth grade, I think. He was actually having PVCs, which means his heart was having extra beats while he was playing in the basketball game, and it caused him pain, and it was very concerning to me. So from that point on, we had yearly EKGs for him just to ensure that he's not having any issues. And if we did that and made that a standard for every athlete, then we would know what things look like before they got on the court, right? It would help us determine how we would, or on the field, how we would take care of them. And also to get the buy-in and to have everyone to understand, or that awareness that we need to have an AED, and we need to have it not just in high school, we need to have it at a rec center, we need to have it everywhere.
I'm surprised like that hasn't become like a mandate, especially with the number of sudden deaths that we've seen in the recent past, in school age.
We have ambulances. When we grew up, there was an ambulance at the football game or at the basketball game. Every game there was a paramedic crew, right? There is no paramedic crew or anything anymore.
Do they have do they have physicians with the high school players that travel, or some type of team doctor?
Yeah, they do.
And does that team doctor, what's their
they still have a physician? Most schools have a physician
that travels to each game or is present at each game.
Right.
Right. And so the life-saving methods is going to be CPR and not AED.
Right. But if you're in most cases, if you're in BFID, most oftentimes or not, you need to have some type of implementation, right? To save your life. I mean, CPR works, but if you're in BFib, you really need to have that fibrillation, that shock, in order to just stop your heart and start it in a normal rhythm. So that's very dear to me, and I'm thinking long and hard about how I want to approach it, and if I want to approach it and delve in it. But it's something that we as a people should be aware of and make a priority.
Yeah, maybe try to fight for that at your school. If there is a budget and you have the option to be a part of decision making, go to parent planning meetings with the school and see, talk to the coaches and see if they have extra money, or if you can even do fundraisers, perhaps. If the school can't find budgets, find different ways to try to purchase an AED, to have it on staff and make sure that someone's trained to be able to utilize it. Right. In the event that something like that does happen.
And learn how to do CPR. Everybody should know how to do CPR, but most of us don't. Mm-hmm. But if you could take a CPR class, I teach CPR. I teach ACLS to nurses. But lay people couldn't learn how to do CPR as well. Mm-hmm. So if you have the opportunity to learn CPR, you never know when you're going to need to use it. But to know how to do it surely saves a life.
Yes. So for people, there are, in males in particular, it seems like, Ray, I see your question. We'll speak on it in just a second. Okay. She asked about congestive heart failure. Mm-hmm. Mm-hmm. But in males, I think it's good to know our history to it. Mm-hmm. Especially in males. I don't know if it's the same in women, but I know it is in men. So you'll see like families, and this is to talk about genetics again, that were other men pretty much at the 50-ish, At 51 to 55, they drop dead of heart attacks. And a lot of that is because there is a genetic predisposition for heart disease of some sort. And it seems that by a certain time in their life, that's when their structures or whatever have failed and they end up passing away. But in that case, I don't know that AD would change things, but I'm not sure. What do you know? What do you think about it?
Well, most times, if you have that predisposition of having cardiac disease, you're going to already have a cardiologist on board. It's when you don't know. But most people know, and they have a cardiologist and that they're seeing. Now, if a cardiologist works you up or does an assessment or evaluation and determine that you may be at risk for just sudden cardiac arrest or at risk for going into VTAC or VFib, they will normally assess you to see if you need a device such as a pacemaker or a defibrillator, an implantable one. Right. Where you keep it out at all times, it's implanted in your chest, and it detects every heartbeat that you have. So if you don't have that heartbeat, it will kick in, or if you have a fibrillation, it will shock you so that so it's a means of protection, right? So most oftentimes you will have, if you have that predisposition for cardiac disease, and or your family history is you've had a mom and a dad to die by 50 of heart attacks, they will work you up in that manner.
That's the key thing is, one, knowing your history, because a lot of times we're not connected to our fathers. I mean, right. I say that I didn't know my father really until he was almost deceased. And two is getting that routine visit to your doctor and being seen and talking about the symptoms that you have, the chest pressure. Right. I have a friend of mine now, he's talking about he gets chest pressure. His dad died when he was 50-something years old. I said, dude, you need to get to the hospital. Absolutely. And you need to be checked. He has
not the hospital. He needs to go to his doctor.
His doctor, exactly. Right. But I mean, in the middle of chest pain, I say go to the hospital. Instead of go to your doctor. So right. I mean, that's like in the middle of episode, instead of waiting for an appointment, you're going to have to get that later. But if you're in the middle of an episode, you need to go to a place where they can handle urgent matters, which is not your doctor's office. That's right. The hospital.
Right.
But, he dismisses it and not really put a whole lot of attention to it, which I think a lot of Black males do, which is what my cousin did, taking antacids because he thought he was having heartburn. Yeah. And 3 days later, when his co-workers was like, where is he? It's not like him not to be at work. And they found him in his bathroom, and the pills were on the floor. He was trying to take them, but he had a massive heart attack. So a lot of times people just don't, first of all, listen to their body and take heed to the warnings, and then don't go take that extra step and have routine checkups by their doctors and take them like the measures that you described in terms of letting them make a recommendation based on what their actual problem is. So I'll let you address Raina's question here. Can you speak about congestive heart failure?
So congestive heart failure is it's genetic as well. Heart failure though affects it doesn't necessarily affect the arteries, it affects the ventricles mostly. Heart failure is so the heart has 4 chambers, and I don't want to get too detailed, but it does have 4 chambers, right? A right and 2 sides, a right and a left side, right atrium, left atrium, and a right ventricle and a left ventricle. So you can have 2 types of heart failure. You can have a right-sided heart failure where the right side of your heart is affected, or you can have a left-sided heart failure. And normally it's like what I was telling you about my hypertension. So normally a person who has congestive heart failure has severe hypertension, and that diastolic pressure is always like 100 and above, and like they can't get any. There's no management to get that, in a normal range, like 120 over 80 or 110 over 70 now, right? So because there's so much pressure that your heart has to push against, it becomes boggy. So that leads to heart failure, because if your heart isn't able to pump the blood out, then it has no choice but to either sit or go backwards. And so then that leads to the heart failure. So they manage heart failure in several different ways. They give you, say, diuretics to help you pull out fluids. They give you medications called like Coreg, what works directly on the ventricles and helps to improve what we call ejection fraction, but you guys may call pumping mechanism. It helps to improve that. So in heart failure, what's affected mostly is the pump of your heart. And when that's affected, then the amount of blood that you pump out, or the volume of blood that you pump out, isn't the amount that's needed, right? So that leads to the heart failure. But what's good about I don't want to say what's good about heart failure, but it's treatable if you catch the time.
Catch it early. I'm sorry to interrupt you, Ronnie. I want to make sure we say we are at our hour mark, and I just realized time is fast. It's 7:30 already.
It's 7:30.
Yes. So we're gonna have to do round 2. All right. But it's a great conversation. We kind of went in some different directions as you talked. I thought we found some good stuff, but I want to be able to save it so we can all have it to do a replay later. So let me go ahead and thank you all for joining us. This is my dear friend. As you can see, she's very knowledgeable about the heart. And, if you want to know more and grow more about, and understand more about your heart, she's the person to follow and to get some information from. I'm Dr. Teresa Bristol. I'm a physical therapist, entrepreneur. I am launching my coaching business. So please DM me your email address so that I can send you my newsletter so you can find out more great things. There are a lot of ways we can make money, right? And this is one of them. I can help you, educate you, help you find your gifts, build your businesses, and bring autonomy and love to your life, because I do love what I do every day, right? Take care. God bless you. Thank you so much for joining me, Rhonda, and we will talk soon, okay?
Thank you for having me.